Good evening, everybody. I'm Dr. Eileen West. I'm a general internist in Fairfax, Virginia, and I am excited tonight to be able to speak with you, also with Lisa Larkin, who is a physician in Cincinnati and founder and CEO of Miss Medicine. I'm so excited to have you here tonight. Thank you so much for coming, Lisa.
Thank you so much for having me, Dr. West. I'm really happy to be here with you.
We were just remembering that this is almost 2 years to the day since our very first phone call, and how I remember after a lengthy phone call, I hung up the phone and immediately bought a plane ticket to come to Cincinnati so that I could see what it was that you were doing, because I felt like we had so many similarities and so many common interests and just a real passion career-wise that for both of us has extended 20 years or more. And,
right.
It's really nice to find a kindred spirit.
Right, for sure. We sisters separated by birth. Sisters by a different mother. What's the saying, right?
So I thought that everybody might be interested tonight to have a chance to hear from you a little bit about how Miss Medicine got started. And about, well, first of all, but before we jump into Miss Medicine, I'd like to hear just a little bit more about your background and about how you became interested in this area of, internal medicine, women's health. It's not often that you bump into a lot of people who really care about women's health who are internists. Normally it's in the purview of the GYNs. And so I would just, I'm curious to hear how you got interested in it and how you got started with the whole field.
Well, sure. I'd love to tell you that story, but I would really start first by saying kudos to you and just say how grateful I am to have you as part of the Ms. Medicine family, because you are all about quality and high quality women's health, and you are exactly the person and partner that I want to have as part of our growing network of Ms. Medicine providers. And so kudos to you, because thrilled that you were the first and you're still the greatest, right? I'm very happy to have you as part of the, network for sure.
Definitely in 2 years.
Right. Time goes fast. So I would start by saying, I'm always kind of a square peg in a round hole. And I've always been a little bit of an outlier in kind of the way that I do things. There was no question in medical school 100% that internal medicine was my thing. It was what got me the most excited, and it's problem solving, and it is very diverse diseases, and it is all about longitudinal patient care. And I made absolutely the right choice in doing internal medicine, although I loved OBGYN as well. But really, ultimately, it came down to delivering babies was fun, and I loved it and very exciting. But really, I wanted much longer term relationships and more complex diseases and problem solving. So that's how I landed in internal medicine. The women's health piece really came organically at the beginning, which is as a women's health internist. In academics, I started seeing female faculty members. They kind of gravitated to me. So I had a bulk of relative, not exclusively women by any stretch, but very early in my career, it was very apparent that people weren't really interested in diseases that affect women. And I was seeing a lot of menopause, and I was, just overwhelmed with the number of patients who were coming to me for menopause and not a lot of accurate information. And so very early in my career, I really saw this unmet need and really started developing a niche. So I got very involved in the North American Menopause Society, did some online curriculum and training, started to develop really a niche within academics. And it really just continued to grow from there. I spent 12 years in academics. I then left just before the big study, the Women's Health Initiative data broke. I say that the journey of hormone therapy has defined my professional career, because it's been this, wandering, circuitous journey of hormones are good, hormones are bad. Now we're back somewhere in the middle. But what's been really interesting for me and led to the founding of Ms. Medicine is, frankly, the lack of significant improvement in women's health care over 30 years of my career. And I would say it's starting to be recognized in what the issues are, and that there's really this big gender as well as racial disparity in care. But part of it is really the way we have thought about women's health, right? So just as you said, the majority of women's health, everyone thinks of that's OBGYN. Well, what OBGYN focuses on in women's health, obviously, is contraception and pap smears and delivering babies and surgery, right? So it's all about reproductive organs. And the lens that we have all thought about women is just that we're different than men just because we have babies and we have different reproductive organs and different hormones. But the fact of the matter is that we're genetically different down to every single cell in our body compared to men. And so diseases, actually, when you think about it, it's no surprise that diseases that present in both men and women are probably different in women. And we know this is Heart Awareness Month, right? We know that cardiovascular disease in women is completely different than men. And yet for decades, what we've done is we've only done clinical trials on men. The aspirin studies are really a good one. We've taken data completely done in men and we've applied them to women all these years, thinking that we're just smaller men. And the fact of the matter is that that's not correct. We've made huge mistakes, and that incorrect lens of our differences has led to just these huge gaps in our understanding of how diseases present in women. So heart disease is a good example, which is men form plaque in their coronary arteries different than women do. They have smaller vessels. Women produce plaque more diffusely along the vessel. Men have bulk plaque. No surprise, women have different symptoms than when they have coronary disease, right? And we keep calling women's symptoms as atypical chest pain. Well, I'm not really sure why it's atypical, since we make up 50% of the population and heart disease is still the leading cause of death of women. But again, it's been this whole journey over my career of just really recognizing the gaps in care and really trying in my own individual practice and developing that both within academics and in private practice to try to, with individual patients, improve care. And as I've gotten to what I say is really my last hurrah, really probably the last 10, 12 years of my professional career, really Ms. Medicine grew out of kind of wanting to have an impact and do more in terms of advancing women's health because, and I didn't really say this well, but because women's health is not just OBGYN, right? So all of these diseases as women age, it's bone health, right? Your focus and your expertise, Eileen, right? So women disproportionately have anxiety and depression. They disproportionately, their coronary disease is different. They have osteoporosis, which is very different. Another area that has, really been neglected. And we know we're not doing an adequate job in bone health with women. But the bottom line is you need women's health internists in addition to OBGYN. And just like Eileen, she's a rare bird as well doing this, but there aren't that many of us across the United States who have really started to form this niche in women's health because really there are things that we should be doing both in cardiovascular disease and bone health, in breast health, in female sexual dysfunction, in menopause, in cancer survivorship that we know we're just not doing an adequate job. And we need more internists in addition to the OBGYNs, because of course we need them too, because women's health just isn't one specialty. So long answer to.
No, that's great. And I first heard it referred to bikini medicine some time ago, and to me that really summarized so much of when people think of women's health, that's really the first thing that comes to mind. And it's that the bikini zones. But the reality is that it's the whole body. And you have to pay attention. You have to take it all into consideration. And I think we're getting better. I think we're moving the needle little by little. I really feel that there's more attention being paid to all of the different processes that women experience and the different risk factors that women have. But we still have such a long way to go.
Right, for sure. For sure.
That's great. Did you have any particular aha moment or a time that just said, wow, we have to do this on a bigger scale? Well, for you opened your practice in Cincinnati,
right?
And you found that you had a really terrific response to what it was that you were wanting to build, right?
Correct. So I was in academics for 12 years, first part of my career, I left and started an independent women's focused practice in 2002, just before the Women's Health Initiative data came out. So that was a big boom because there was I was already doing a lot of consumer education in menopause and women's health. And then everybody was really confused. So that was really great for my practice. And I built that practice into a multi-specialty women's health practice in Cincinnati that was very successful. And at that point, I wanted to do something bigger as well. So I actually sold my practice in 2012, went back into academics, this time in the OBGYN department, and opened a large multi-specialty women's health center within a large academic center. And for reasons that are long and complicated, but the short version of the story is I really couldn't execute and advance women's health within the confines of the academic center the way that I had hoped and envisioned and wanted to. Because when I went back in, frankly, I thought I would end my career back in academics because I love the resident and the medical student interaction and the teaching part. But it was really, again, I was really handcuffed in that organization and really struggled to execute anything. At the same time, I had breast cancer during that stint. And I think the combination of realizing the first time around that I could successfully run a practice and could have independence and do something with that, and then also feeling like life is short and I need to make an impact if I'm going to do it, and I don't want to spend my last years beating my head against the wall and really struggling to execute anything, I made the decision to leave again. So I resigned from there and relaunched my practice in 2016, and then launched Ms. Medicine in late 2018, early 2019. And, this really then the aha moment was just, my practice is doing well again. And, certainly I have patients and I can contribute one-on-one to patients, but there's just work to be done. There's just, and work on the internal medicine side. So to your point, and in the North American Menopause Society, an organization that I'm very proud to be affiliated with, that's been my home base for many, many, many years, where, it's an incredible network, and anyone that's interested in the space should be involved in NAMS. But NAMS is primarily, not exclusive, but it's, primarily OBGYN as well. And not that they don't value the internal medicine people. And that's what I love about the organization, is that it's very multidisciplinary, but we're still a smaller group. And Eileen, you know this, right? Which is, if we really are going to make an impact and raise the standard of care for women, we have to have internal medicine and family medicine involved in the mission as well, because there just frankly aren't enough OBGYNs. And so Ms. Medicine really came out of, again, feeling like I have one last venture to do. And, because life is short and I'm getting old, and really wanted to see if I could make an impact by forming this network of women's health clinicians across the US. And that's really where Ms. Medicine comes from.
Well, it's wonderful. And so in just 2 short years, we've accomplished a lot. I mean, you have driven this and you have figured out how to make all this happen. And it's been a real pleasure to be part of it and to be assisting in the process. And you had one office location at the beginning of 2019. By the end of 2019, you had a second location in Northern Virginia, which was my office. And now, a year later, you're following that, there are 5 locations.
Right. So we just opened Naples is the most recent one, and I'm heading down there. Just did an event with Dr. Stewart today, a virtual event, but I'm heading down there to do an outdoor, socially distant opening event with her, which I hope with COVID we can do someday in DC again too, and really do the open house in the way that we sadly were not really able to do it the last time due to COVID for you, right?
Scheduled in early April of 2020. Right. There was nothing
just shut down the world. But yeah, it's we are a startup. And things are moving very fast. And with each segment of my career, it's been a new set of experiences. And I bet for you, Eileen, you could really talk about that too, right? Leaving an employed academic, system and now running your own practice. And I mean, what the 2, years have been like for you, 1.5 years or year plus now, right? You're at about 15 months open now, right? how much you've learned, right? Because it's a whole new set of skills and a whole new set of things. And that's been my experience too, frankly, when I talk to young physicians, including my daughter, who's a recent medical school graduate. The best thing about medicine, I think, for women and for men, but is that your career can evolve over time. And I really see very specific segments, of my career. And the Ms. Medicine is, I think, probably my last big segment anyway, in terms of seeing what to do with this. And although, thank you for celebrating the things that we have accomplished. And we have worked very hard, all of us, you included. There's lots of work to do, and to really make an impact, we have to have a bigger network. And so that's really where the emphasis for, this year really is is really expanding our network. And then, as the educational initiatives for both consumers and physicians is really a passion of mine. And again, a way that I believe that we can impact the health of women in a way, even if they're not a member in one of our Ms. Medicine practices, right? Because, just education empowers women to be better advocates for their own healthcare. And there's so much noise out there in the social media space, and there's so much direct-to-consumer marketing of things that it's very hard for women to sort out what's good information and what's bad information. And so the education really kind of hopefully helps in that way, so that women can get good information and be better advocates for their own health.
Absolutely. And what I love about the whole organization is this multifactorial component to it. It's, being able to be a part of a physician executive group is like having a red phone to some of the top specialists in the country. I mean, we're on first name basis. We can speak with people. We can ask our questions. We can start chat groups and ask medical information. There are so many ways that is beneficial, but I really feel like we're passing it forward as well by being able to train people who are in primary care now and want to do better with women's health. And so that's what, to me, they are getting solid, excellently presented, evidence-based information at every one of these case conferences. And I'm learning something each and every time. And this is 20 years of being in the field. I'm still learning something every time. Right. And that's really gratifying.
Right. Great. I mean, and I would say too, right? I mean, there's lots of great things about being a doctor, and, it's a privilege to take care of patients, but, for the nerdy part, and, if people who knew me in college, actually probably all my life, would say I'm pretty nerdy, right? So I always sit in the front row and, funny, whatever, at meetings and stuff. But the science is really cool. And the research is really cool. And I really say I don't know about you, and I think it's true, actually. You and I have talked so much over this year about COVID and COVID testing and COVID vaccination and COVID presentations and all of that kind of stuff, that COVID's been, a really interesting scientific experience for all of us. Lots of new, cool information to learn, lots of science there, that makes medicine really interesting. And in the women's health space, that's for sure true, right? There's just evolving data and really cool science. I mean, I when I lecture now about migraines, I say that this is really an incredible time in the field of migraines, where basic science, really high quality. We understand the pathophysiology of migraines now in a way that we didn't understand. And that has led to really incredible new drug development. I mean, it's a great story of how science works. I mean, and I think I can say that about the COVID vaccine development too, which has gone so well, right? It really is, some of the fun part of medicine. And in doing, one-on-one practice like you're doing and like I'm doing, Eileen, the network with other like-minded, our tribe, right? Either at NAMS or within our discussion group forums, right? That really is, again, another really valuable part of, and fun part of practicing medicine. That's really great. So it's really important to me too, just, like you, right? Because I learn something all the time too. And that's what makes it fun.
Well, when I first decided to go to medical school, one of the main things that really drove and motivated me was this concept that I would go to bed at night knowing something that I didn't know when I woke up in the morning. And the thought of being able to spend a lifetime doing that was really enticing. And it has largely panned out to be true. It's really, and not only it's just learning something, but it's learning something that really is beneficial for people. Just makes it so rewarding. So that's great. Good. Well, you have done a lot of work you're very, very interested in technology and the telehealth and telemedicine space. And I'm curious to hear a little bit about some of the things that you've explored and some of the things that you're excited about in that arena.
Well, first of all, I mean, Eileen, I am not a technology giant. My team, if they were listening to your question right there, would laugh, frankly, because I have lots of ideas. But, my son is a computer software engineer. And I literally, when he talks to me, I'm like, John, you're talking Chinese. I don't know what you're saying. I want to be interested in what you're saying, but I don't understand. I just don't. So I have lots of ideas about telemedicine and lots of experience and know what I want to do with telemedicine. But I'm not the tech person and I don't understand all the back room stuff. But I can tell you, being in the startup space and with COVID, you really can see that there is opportunity and room to use technology to improve patient care in a lot of ways. Just for example, being able to use telemedicine to reach people who don't have access to specialists, for example, right? In a way that you can't do it if they live, in a rural part of a community 200 miles from a major metropolitan area where there's, specialists. So, there's parts of the telemedicine that are just amazing. And we certainly learned and saw that with COVID, I think, right? Which is being able to quickly pivot and be able to deliver care to people remotely and virtually and through these platforms has been really, really positive. The negative part, or what I kind of say is negative, though, is what I don't want is kind of the journey of the hormone therapy, right? Where it was really, really all positive, and then we figured out it was really, really all negative, and it took us 20 years to kind of come back to the middle, which is and there's lots of companies in the space now and lots of technology. We've been really running at breakneck speed to make everything telemedicine now, right? And so they've gone to whole companies which are entirely telemedicine based, where you really don't have in-person care. And I actually have real concerns about that, which is telemedicine means many different things, right? So telemedicine, and I'm not sure I'd call it telemedicine exactly, right? For the big companies, Hims and Hers and Rory and Rowe that you see advertised, where they're selling, prescriptions basically, or you have a doctor's appointment on, through a chat bot, and you can get your prescription for your hair product or your, all different medications, birth control pills, hormone therapy, whatever it is. But you never have really any contact with the doctor. It's all done through kind of a questionnaire. Then there's other telemedicine where you have virtual visits, but you really don't have an established relationship with the physician. And then there's where really I think that telemedicine is the right way to do it, in my opinion, and not for all things, right? I think mental health, behavioral health, you probably can do almost entirely through telemedicine, and that's been a great thing. But where telemedicine I think is really, really valuable is in the situation where you have a doctor that knows you, the doctor's seen you, the doctor's got a complete chart with your complete medical history and your medications and your allergies, and has a relationship, so can follow up with you, and you have a place to go if whatever you did the telemedicine visit for doesn't get better, gets worse, where you have kind of this ongoing relationship, which not all of the telemedicine, in fact, most of them do not have any way to do, right? So they're single visits without longitudinal follow-up. And so my big concern is, without having telemedicine affiliated with a doctor or a practice, which is the way that I think that it should be done, and which is the way that I want to build it with Ms. Medicine, is that, again, we'll have delay in diagnosis or misdiagnosis of things, and that there really is value and the need for certain things to have in-person care. And so, as you know, the direction that we're going with our practices is certainly to do telemedicine as a component, but it's not, for most things, an independent one-off thing. Now, as much as I say that, I think there are discussions that you can have with a physician that are really well suited to telemedicine. So for example, and I know you do a lot of this as well, Eileen, really trying to help women understand their actual risk of breast cancer, having a conversation with them, being able to do modeling for them, to assess their risk for needing genetic hereditary cancer screening, right? Those are things that really don't require a physical exam and really can be, I think, a great thing to do as an add-on in the virtual space. But again, where I always worry is even in that setting, if you do that as a one-off for someone, right, it's really giving them information to make sure that there's a person that they can go see to talk about that, right? So if I give a woman information about her breast cancer risk, she needs to take that information back to her primary care doctor because you have to do something with that information, right? So if they meet criteria for enhanced screening or they need genetic testing, how do we really, really do that? And so again, I'm all about adding technology to Ms. Medicine, but in an adjunctive way to our in-person practices.
Mm-hmm. And being conscious all the while of what's evidence-based and what isn't, which is really, if it's going to be sustainable and last, that's what it needs.
Right. And not to slam, technology, because the artificial intelligence, some things, right? You've seen it too, like, some of the things, it's amazing what really we can do more efficiently and better, lower cost, have improved access to underserved communities. Like there's great aspects of what telemedicine can do. Like we're going to get a big snowstorm here tonight. So I've already been trying to look tomorrow at which of my patients I can do telemedicine so they don't drive in the snow, right? 80-year-olds, I don't want you slipping on the ice outside my office and breaking your hip coming to see me. There are some things that in the short term we can manage through telemedicine and see you in a week or two. So navigating that, and that again is one of the nice things about technology, and also the nice things about having your own practice where you can quickly navigate and your patients well to make changes in a snowstorm that we're getting tonight.
Exactly. And we had the conversation now among my staff. We have a plan for tomorrow. If the snow that's supposed to roll in at 2 a.m. is as meaningful as they say it's going to be, then, we'll still have our team meeting at 8 a.m., but we'll be working on our laptops from our dining room tables.
Right.
And, it's doable. I really think that we can, for short term, we can accomplish quite a bit that way, which is, it's the first time that has felt like an option. It's just there will be some pluses to this whole experience that come out of it. People understanding how to adapt will be one of them. Yeah. So that's great. So tell us a little bit about what you're envisioning for the next 6 to 12 months. Do you have any thoughts about what your, what are the projects or the I know that continuing to expand is high on the priority list. I also know that you're really working hard to develop this Miss Med Ed program. And now we're doing weekly case sessions, which any practitioner who's interested
can join, which is great. It's well over 100 people who have registered. Now, obviously not everyone gets on every week, and it's been a smattering of people, right? So we've had between 25 and 35 each week, but a good number. And certainly as you've been on most of them or all of them, the discussion is robust and fun. And I think we all learn, and that's really great. The consumer events, I want to get back to, so you remember before things shut down, we were doing in-person events, and then everything shut down and we did some virtual events this summer. But again, I think, who knows what 2021 as we roll out the vaccine is really all going to be. I would love to say that we could start to do some in-person events with a virtual component, right? We've learned all these new different ways of doing things, but the education piece is really important. The other thing, we're working on a couple things actually, and I don't even think the third one yet, because this is really happening quickly. So we've launched, I'm doing right now our pilot executive health program in Cincinnati, Leadership Health 360. That we hope once we get we're doing 5 patients in Cincinnati to start. And then I hope really to roll that out with you, Eileen, in DC, and with our other providers, really to offer kind of a comprehensive one-day wellness that obviously you would see Dr. West if you're in the DC area, but really putting it together where it's really an entire wellness day, and you can add on the concierge services for the year after that if you want, or you can make it a one-day program. So that's number one. The second is really direct-to-employer initiatives, where really, again, trying to capture a market where wellness is a priority and largely in self-insured companies. So we're working on that as well. And then the third thing is and I did mention this to you when I was on the phone with your husband and you this weekend, but really hoping to develop a clinical trial program through all of our sites, doing some women's health research, and that's moving along really well too. So how far we'll get on all three of those this year, certainly the Leadership Health 360 will open. The education events events and the curriculum and all that kind of stuff is really in the works. And then we have a aggressive timeline for how many providers to expand the network in 2021. And, I have a small but mighty team. They're working really hard. And, as you know, Eileen, there have been learnings for me along the way of this. This is a real startup, and we have really learned, and that, and we're getting better every day. And with each new rollout of the next physician, we're more streamlined and more efficient. And so this is a big year for us, I think. I think my hope is that we will really have geographic distribution. Clearly, we won't be in all 50 states, for a long time probably, but at least have West Coast distribution and a little more diverse network by the end of the year. And we have some really exciting prospects that we've been talking to that we're very close with, that I'm super excited about and hope will join, and hope, we'll see, but we're working pretty hard on that. So.
Fantastic. All good. Many, many good things to come.
Yeah.
So.
Thank you. And you want to